Cormac will put them up on our website via his YouTube channel. I think that's the way he does it.
Lovely. I'll download.
Because you're not streaming them to Vimeo or YouTube, sure you're not?
No.
No.
No, we just take them. I just take them straight down from the
Yeah, from the
Microsoft Teams.
Yeah. Okay, so we can talk about that again. But yeah, if I could get them up this week, would be great. So yeah, when Sinead finishes, I'll just say that as well when we're starting, which will be in the next 2 or 3 minutes. But also I'll mention the event in the RCSI tomorrow.
Oh, thank you.
No problem. No problem.
My washing machine will have finished by the time we're starting. If you can hear it in the background, I've just checked.
Can you hear my printer going here? No.
No.
Good.
No.
Okay.
My headset, I found it upstairs in Matt's bedroom. So he's been on online gaming with my headset and he's managed to break it. So yeah.
Yes. Your sound is great though.
Is it? Okay, good.
Yeah.
Good.
Yeah. So Sinead, it looks like there's a combination of things going on here. I guess people are flat out lack of staffing. It seems to be less people available at this time to attend, and I'm getting to think it's a Christmas thing, a vaccine thing. It's just we're coming too close to the chaos, really. So that's why I'm anxious to get the recordings up.
Yeah.
When I just want to clarify, even though colleagues can hear me online now, but when you're working in Ballyfermot at home care team, am I correct in that? Yeah. You haven't changed or anything with that?
No. But so my clinical work happens there, but I'm available to the whole of the CHO7.
I was going to ask you that. Are you all of CHO7? Yeah.
Yeah. The service owns me for all bits that aren't clinical. Service owns me. Yeah.
And there was something I was going to ask you. When did you finally register as an AMP in the end? It was 2018, was it?
I registered as I was a candidate up until 2 years in AMP now, maybe 2019.
You've lost a couple of years in between. It actually popped into my, it doesn't really matter when we listen to this, but popped into my diary there the other day when you became a fellow.
Yes.
I think there was a snow episode that day as well.
Was there?
Yeah, there was some sort of an episode that day as well.
God.
Yeah, it wasn't as bad, but we all were on the train, I think, or something. It was bad.
Yeah. That was a good day, actually.
Yeah.
Okay. 19 I registered. Yeah.
19 you registered. Okay, so we'll kick off if that's okay with you.
Sure,
because we're live and Anya, who's in charge of us, is recording us. So good morning, colleagues. Ash and Culhane here from the P&A, broadcasting live from sunny Portlaoise on the last of our P&A RCSI webinars for this series. And thanks and welcome to Sinead Frain, member of the P&A, fellow of the faculty of the RCSI, nursing and midwifery faculty. Also, she is one of our, I suppose, consistent and resilient, enduring AMPs. For those of you who are on that pathway, you know that it's a great career, but it's hard work and it does require digging in and digging down. And I was just having the chat with Sinead before we began to remind us of when she started her candidature in 2018, and she's registered AMP since 2019. Sinead works with the Ballyfermot home care based team, but as she has pointed out to me, her remit covers the whole of CHO7, which is the Dublin West Southwest services, a very busy service. I worked there myself at one point. And today's, for those of you, in case you can't see it or you're on live, is working with patients to seek early intervention and relapse. Sinead's going to go with us with a hard stop at about 12:15 this morning, going into the afternoon. Unfortunately, I can't join you towards the end because I have to go to another meeting. So, which brings me to the point that I'd like to share with you as collaborators and service providers and indeed partners. I have sent out details of tomorrow's gathering for fellows and friends of the Faculty of Nursing Midwifery in the RCSI, which is a beautiful event that takes place on the 16th of December tomorrow at 7 p.m. I do know they will record it, but if for those of you who wish to join, I've sent the details out and the link to all PNA members. And the other thing I'd like to share with you as well before we close is that these recordings will be made available live up onto the PNA website, which we hope to get up over before we finish at Christmas, so that they're available to you over the Christmas and into the new year, because we recognise the fact that this is an extremely busy time at the moment in services. We're all under extreme pressure, bouncing from one thing to the other, between vaccinations, Christmas, and indeed staff shortages, etc. So we recognise that, and that's why it's anxious that Sinead we're joined here by colleagues, and it's lovely to see you all. We know that there is a bigger cohort of you out there that wants to engage with us. So as soon as possible, with the help of Anya and Catherine Clumavani, who's operations in the RCSI, we will get all recordings from this particular series of the PNA RCSI webinar series up on our website ASAP. And without further ado, I'd just like to thank colleagues Anya and Catherine Clumavani and indeed Sinead for their dedication, work and cooperation and indeed friendship with the PNA over the last year. It's been, as usual, great to work with you all. Been great to see you all. If you could share the fact that we're putting these recordings live up on our website with your colleagues, for those that couldn't attend. And I'll pass you over to Sinead, and many thanks. Wishing you all a very happy Christmas and see you in the new year. Thanks, Sinead.
Happy Christmas, Aisling. Thanks, Aisling, and happy Christmas to everybody. Getting that we can say that now and not be embarrassed. It's only a week away. Anyways, good morning, everybody. So this morning I am literally just going to take you through working with people to seek early intervention in relapse. And this is, I suppose, part and parcel of my practice. So I'm just going to share some insights with you, and just how about, I suppose, I go about my business, and kind of a fairly practically focused presentation. So I think if everyone could just silence their microphones, that would be great, because I'm just having some background noise there. I'd appreciate it, and we'll get started. I can take some questions at the end if there is any. If you could hold your questions to the end, that would be great. Anya, my screen isn't moving on for some reason. And it was. There we are.
Oh,
that's it. Yeah, I have control now. Yeah, perfect. Thanks, Anya. Okay, so what is relapse? And this is, like, in layman's terms, it's the worsening or emergence of symptoms. So there are people who always have symptoms but carry on about their business. They have residual symptoms, but they get worse, or people who are symptom-free and their symptoms start to emerge. Okay, and every single solitary person will have a different relapse prevention or a different relapse signature. So that's basically what relapse is. Okay, so what is relapse prevention? So it's working with our patients to develop and tailor an approach or a plan that we activate when a person becomes unwell. Okay, so it's having a plan in place that if somebody becomes unwell, that we can activate that plan. All right, and it's also about allowing our patients to feel in control if they start to relapse. So there's a plan in place that a person knows, well, if I start to relapse, I can do X, Y, and Z. Okay, so to allow your patients to retain control when they're under stress. Okay, so the rationale for relapse prevention is so that we can identify when things are getting worse and halt the deterioration before it becomes too bad. So basically, as I do say to my patients, this plan is designed that if you do have symptoms again, that we catch you before you fall. It's just about trying to prevent things from getting into such a place that it's catastrophic for a patient. Why should we bother doing relapse prevention? So the research out there would say that there's huge relapse rates in schizophrenics. So if we consider the proportion of our population that have schizophrenia, it's really important that we have this plan in place for them. So 60 to 75% people with schizophrenia will relapse because they've discontinued their medication. And part of the relapse prevention plan, I suppose, is actually working with people and looking at people going, well, why are you stopping your medication? Are you having side effects? Do you think you don't need it? What is it? So, you know, that part forms part and parcel of it. 40% of people will relapse with medication. So people are like, well, I'm taking my medication, so what's going on? So the part of the relapse prevention plan with that cohort of patients is to look at what else is going on. Yes, they are taking their medication, but what else is going on for them that's causing a relapse? 20% of people will relapse with medication combined with psychosocial interventions. So there's a cohort of the population that will have had psychosocial interventions and have had medication, but they still relapse. But we need to look at why that is. If we look at bipolar disorder, 95% of the people with bipolar disorder will have a recurrent episode. So that's another huge chunk of the population of people we look after. 50% of people with bipolar disorder will relapse within a year, and 75% will relapse within 5 years. So there's a huge amount of people that we look after who have bipolar disorder and who have schizophrenia, who are likely to relapse. So if it's likely that they're going to relapse, then surely it makes sense that if we suspect that these people are going to relapse, that we need to have a plan in place to mitigate against it, or if it does happen, so that we can ensure that it doesn't turn into a really horrific event for the person. Okay, so Kennedy and et al. Would say that people are able to identify their personal symptoms of relapse. And sometimes people employ various mechanisms to manage these symptoms. At least 80% of individuals with mood disorder can identify that they're having symptoms or what their prodromal symptoms are. Patients with a mood disorder are also higher risk of suicide. And work on early warning signs might prevent the escalation of frank psychosis symptoms. Okay, so clearly what the research is saying is that people are sometimes able to identify their prodromal symptoms, and that, you know, we can build on that with people, you know, to try and stop them from becoming so unwell. All right, so there are potential problems with conducting a relapse prevention plan, and we need to be aware of these, and we need to try and work around these problems as well. So the first problem is lack of insight. Okay, so people who are unable to conceptualize their psychotic experiences as being unreal, they can find a rationale behind them. Sometimes people just refuse to participate. They don't want to get involved. People, you know, attribute their experiences as being real, but they blame something else. Or an early loss of insight, which is a frequent one for our patients. So that when they start to become unwell, their insight goes out the window really, really quickly. Yeah. If a person is unwilling to participate in a relapse prevention plan, you can ask for their permission to speak to their family members. And there's often a lot of rich information that you can get from family members about a person's relapse prevention signature, or what was going on for them just prior to the relapse. And if you can't work with the patient, if you can get their permission to work with their family, I suppose the idea is that if the family start to recognise that the early warning signs are there, that they can contact us. And I think that that's hugely important. We're not always going to catch everybody before they fall, but this is about, you know, catching them, or, you know, getting to step in there before, for the want of a better expression, the wheels really fall off the wagon. So if we can get in there at the start, we can, you know, sometimes halt the progression of the relapse. Excuse me. So sealing over, okay, so this is related to a person's recovery style, okay, so, and the person who seals over things tends to isolate. It's all, for the want of a better word, it's almost putting things in a box and closing the box and just going, well, you know, that's where that is, that's staying in that box, and we're not talking about it. And what happens a lot with a lot of these people is that when you sit or you try to chat to these people about early warning signs, it can actually be quite traumatic for people. So because we're asking people to go back and to recall, the events that have led up to a relapse for them. Now, we need to be careful about that. We need to be mindful that people sometimes find it very traumatic to look back. And we need to acknowledge that and to manage that and take it slow. And I suppose because of that, there's be a huge there'd be a huge huge focus on the therapeutic alliance. So, and if you have a good therapeutic alliance with somebody, it's easier to tease this sort of information out of people over time. You're not going to sit down and do a relapse prevention plan with somebody in one session. Relapse prevention starts. You can start gathering information for yourself, even if you don't discuss a relapse prevention plan with somebody. You can start gathering information for yourself right from the very first time you meet somebody. You can be saying to them or their family, like, what happened? What was going on? What did you notice before this person started to become unwell? Lack of syndrome stability. So people that we don't know. I mean, there are lots of people who come and go through our service and we know well, and we know exactly when they start to become unwell. But there are lots of people who we don't know very well. They're in the very early stages of their illness, and we're maybe not entirely sure what their diagnosis is. Sometimes their diagnosis only comes to light after a couple of episodes. Sometimes people have a comorbidity that we don't know about, that they're glossing over or that they're minimizing. So, this can also cause a problem. But I suppose what the important thing to say, and the important thing also to say to the people that we look after, is that, okay, if you relapse, it just provides us with another opportunity to clarify things and to look closely at what was going on in the time running up to your relapse. Think about your practice. Do you actually use structured relapse prevention plan when you're working with your clients? Yeah. What is it that you actually do with your clients? Do you sit and talk to them about it? Do you ask their family about it? Is there an assessment tool or a scheme that you use, or do you have a relapse prevention strategy or form that you go through with people? And what does a relapse prevention plan or intervention usually entail for you in your service? In our service, it's not called a relapse prevention plan. We call it a staying well plan. Yeah. So I suppose you need to be looking at, are there steps that you go through and when you actually start relapse prevention planning with people? Yeah. And what I find is, like I said before, the first couple of sessions with people, especially if they're coming to home care and they haven't been in hospital, but there's a relapse and we're picking them up, there's a load of information, a load of really rich information that you can get by just sitting, chatting with people, chatting with their families, and just trying to unpick what it was that was going on. So in my own head, I would be saying, well, there was a lot of stress going on, or their sleep was knocked off, or they became more irritable, or I'd be noting all these things down in the chart, so that when it does come time to discharge somebody, and it could be many, many weeks after that, and that information isn't so fresh in people's minds, that I can go back and go, do you remember when we started talking first? You told me that X, Y, and Z. Okay. So how is it defined? Well, it's poorly defined, as I suppose. So the American Psychiatric Association have said that it's the emergence or exacerbation of symptoms, okay, and it usually preceded by subtle changes in mental function up to 4 weeks prior to an event, okay, and it just means basically that people are getting sicker, and people are getting sick, or their symptoms are getting worse, and it is extremely individual. It just depends on the person. Okay, and relapse prevention just means that a nurse has worked with a client to tailor an approach that promotes personal control when they're under stress. Okay, so is prevention of relapse a goal of your therapeutic practice? Is it something you engage in? Is it something you think you engage in? Right? And if yes, just think about it for a minute. How would you describe your current approach to relapse prevention? Like, what is it that you actually do? So if you were to consider the last 3 clients that you worked with, is there evidence in their chart that the sessions were specific to relapse prevention work? Or, you know, was there a current relapse prevention strategy agreed? Do you currently use a structured relapse prevention strategy, or is it all just written in the chart? So if you go and I do relapse prevention with my patients, and no, it's in the chart, all right? So I suppose if you said yes, then are you actually saying that you actually actively work with clients to understand their specific early warning signs of relapse? And you're aware of their main stressors and coping responses. Have you discussed stress vulnerability with them? Are they aware of the concept? Have you looked at their coping strategies? Do you know their appropriate coping strategies and their inappropriate coping strategies? Do you dig down and drill in with somebody to understand the internal and external, or the internal changes and attributions to stressful events? So what sense are the person making of their stressful events? Do you actually teach coping enhancement strategies? Because if we're really going to look at relapse prevention and staying well with people, we need to look at how they cope. Are you ensuring that people have minimum periods of isolation in their lives? Are you looking at their routine and structure? Are you encouraging, excuse me, positive family support? And is there a specific collaborative written plan on help seeking responses? Is it written down? And when is it indicated? Is it written down? And if so, can your colleagues read it? Do they know where to find it in the chart? If somebody that you're looking after presents to the OPD, or you've discharged them and they're presenting to the OPD and they're saying, I have poor sleep and I'm really irritable and I just can't get washed and I just feel like life's not worth living, or I just can't get washed at the minute. Is that somewhere in the chart that somebody can see, well, these are their early warning signs, things aren't good here, maybe we need to step in? And also, do they have a copy, or do their carer have a copy of the plan? So having looked at all of that, are you absolutely sure that you undertake relapse prevention? Are we really doing it, or are we just doing a little bit of a pick and mix relapse prevention with our patients? This is just worth thinking about. Who's most likely to benefit from a relapse prevention, and how, if we're to really look at relapse prevention, who's going to benefit from all of this? Okay, so people with a repeated history of relapse. Okay, why is this happening? What's going on for this person that they are repeatedly relapsing? Is it their coping? Is it their stress? Is it a psychoeducation thing? What is it? Is it a comorbid thing? What's going on? We need to be looking at that. But the people who are obviously have repeated relapse, they're the ones that we need to be targeting with this. High risk of relapse due to non-adherence with medication. Like I said before, why are they stopping their meds? Is it because of side effects? And if it's because of side effects, well, then we need to take it seriously and we need to address it. Recently recovered from relapse. And like I said just a little while ago, like, they're the people who you will get so much information out of because they've only just recently had a relapse. People who live in a highly critical environment. So people who live in high E environments, so we know that, expressed emotion really, really increases the amount of stress in a house. So the person's stress threshold is increased. And also people who fearful of relapse, or who are demoralized by it. Like, there are people who just go, oh my God, and I just never want to find myself back in that place again, and it's just really important that we can sit down and say to somebody, well, look, let's just sit down, let's have a staying well plan for you. Let's try to mitigate as best we can that this is never going to happen again. And we can do this together. We'll work on this together. So if you use your notepad, can you list 10 negative effects of relapse on a person? And if you like, you can pop some of them into the chat box. So I'll just give you a minute to think about that one. I'm not entirely sure if anybody has popped anything into the chat box, have they, Anya?
So we, excuse me, we did just get one there from Ashleen, checking rituals.
Yeah, yeah.
Has anyone else got anything they'd like to put into the chat box?
Well, if they haven't, it's fine. We can move on.
Okay.
Yeah. So, some of the negative effects of a psychotic relapse or a relapse on anybody. Okay. So, if you have a relapse or if you have, you know, a mental illness episode, it increases the probability of a future relapse. If people who are psychotic have a relapse and they're unwell, the likelihood is that they're going to be left with more residual symptoms with each recurring episode that happens. An increase in social disability. What we know is that with every episode that somebody with, you know, a schizophrenic illness or a psychotic illness, with each illness episode, their social circle shrinks another little bit. They lose social functioning. So their social disability increases. If people are constantly relapsing, it makes sense that there'll be an increase in hospital admissions. So that therein then has a knock-on effect in personal cost and health service cost. So personal cost, you know, sometimes, you know, like a person is so stigmatized if they become unwell and they're psychotic in a public place, or their neighbors have seen they're psychotic or something like that. That's a huge personal cost to someone, not to mention the cost to the health service. The more a person relapses, the poorer their prognosis becomes. And the increase in stigma that I just spoke about, you know, ties in with the personal cost to somebody. There are people who, when they become elated or when they become psychotic or when they become so depressed that they act out on it, and the whole neighborhood knows about it, the whole town knows about it, and they're absolutely mortified. It decreases the quality of life. So that ties in with your social disability as well. Each subsequent relapse, you know, your social circle may shrink back a little bit more. People spending more time unwell is never a good thing. The risk of injury increases. So if you're psychotic or you're depressed or you're related and you're disinhibited, the likelihood of you becoming injured increases exponentially. Okay. So if we think about relapse, we need to look at the risk factors. Okay, so if we look at somebody's illness from psychosocial perspective, we look at a person, you know, in terms of the stress and vulnerability. So interpersonal stress. So if people have a high level of interpersonal stress, that increases the likelihood that they may have a relapse. Okay. If people have lots of life events going on, whether they're negative or positive ones, so it could be the death of a loved one, it could be the loss of a job, or it could be a positive one like moving house or getting married or something that, you know, people would identify as being a really good time in my life. Then that could be seen as a risk factor as well. Isolation is huge. You know, people who are isolated are at huge risk of relapse. Medication reduction or non-adherence. I mean, that's a lot of the time that's a no-brainer. And sometimes people can give up their medication and they can get away with it for months, sometimes years. But when their interpersonal stress levels rise or their life events, you know, life events start to overtake them, they can become unwell. So if you think about somebody that you worked with recently, can you identify any of the above? And I can be fairly certain that there'll be one, two, or maybe all of that going on. So, identifying early warning signs. The majority of clients with psychosis and bipolar disorder relapse at some time in their recovery. Despite the best will in the world, people relapse. And there are some early warning signs common to most relapse prevention focused objectives. Okay, and so if we know that people are likely to relapse, and if we know that there are common early warning signs, then surely to God, we can be ready for it. Okay, so if you wanted to just think for a minute and make a list, what are the common relapse prevention early warning, what are the most common early warning signs? Okay, and most clients, they exhibit a pattern of early warning signs. And if the person you're looking after has a pattern, do you identify that? There's specific ones. And if you do you write it down in the notes? Is it somewhere in the notes, in a person's chart, that can be easily identified by somebody else who is not you looking after the patient? So, sorry now, I just managed to do that slide twice. Okay, so this is an early warning signs questionnaire. Okay, now obviously it is not the Holy Grail. You can add to it. You can you know, if there's things on it that you think are missing, well, that absolutely. But it's a nice little sort of guide to go through when you're doing relapse prevention with somebody. If you're fairly new to it, these are, good questions to ask. So basically, compared to the last week, has there been any increase in the following? It just all comes in as part of the conversation. Are you having problems with your sleep? Is your appetite looked off? Is your mood affected? How's your concentration? Are you able to sit and watch? What do you like to watch on telly? Are you able to sit and watch it? Do you enjoy it? Can you do the crossword? Can you read the paper? Are you finding that you're unable to sit still? That you're unable to relax? Have you tension? Is your neck stiff? Have you pain in your jaw? Do you feel overly anxious? Do you find yourself drinking a bit more or using street drugs more than you ordinarily would? The hearing voice is one, the hallucination one. Are you enjoying things? Looking at people's, paranoia. Is it worse in the last week? There are people we look after who are always a little bit paranoid, but is it worse in the last week? I think that's, the most important thing. Inability to get your mind off one or two things. You overthinking something. Have other symptoms appeared or increased? And if so, what are they? What happened to upset you? Did somebody upset you? Has something happened? Is there something going on? And are you taking your medication as it's being prescribed for you? So these are all questions that we can ask the people that we work with. And you can also ask these questions of a person's carer, not just necessarily the person we're looking after. You can ask them of a carer as well. So, it doesn't matter what way you go about relapse prevention, really. The flow chart here or the diagram here on this slide is representative of what you have to do, regardless of what model you use. So whatever model it is you're using, whether it's a specific model or it's one that's been designed in your service, all of these in the square boxes are stuff that we need to be doing. Yeah. So we need to be looking at, in no particular order. Well, the engagement, I suppose, obviously comes first. We need to be engaging people. We need to be having them on board, having the chats, getting to know them, drilling down into what's going on with them, and building up that therapeutic alliance is really, really big. We also need to be looking at their coping strategies, because what we know from the people that we look after, their coping strategies sometimes are absolutely rubbish, or as are my own sometimes. But the effective coping strategies, they probably have some, but they're just not using them as often as they probably could. So it's about looking at their coping strategies, looking at their early warning signs, going back to this episode. What was going on? What did you notice about yourself? What did your family notice about it? And then once you know what the early warning signs are, there's ongoing monitoring of them, by the family or by their carers. What's somebody's relapse signature? Most people have one. What is there, a common sequence of events? Well, I just noticed that I didn't sleep for a couple of nights. And then after that, I noticed that I just thought that people were a little bit talking about me a little bit more, or that people were giving me strange looks. What is their signature? Most people have one, right? So you need to be looking at that. We also need to put an action plan in place so that if somebody does become unwell, what's going to happen? What are they going to do? What are we going to do? Yeah. So regardless of what model we're going to use, those 5 components are key to every single one. Okay, so this is back in the SAPO model, and like this takes me back to when, I don't know, probably when I was doing my degree. For though it's on the go a long time, anyways. But actually, it makes perfect sense. And I think most of the relapse prevention staying well plans are kind of more or less based around this kind of model. Okay, so it looks at the construction of a relapse prevention signature and drill. Okay, so like I said in the previous slide there, engagement, education, and knowing somebody's stress triggers. Yeah, identification as a relapse prevention signature. So how do you go about this? Early warning signs, the questionnaire we just talked about. Do you use scales? Do you use a timeline? How do you go about it? Development of the relapse prevention drills. This is the steps that take if somebody starts to become unwell. Yeah. So what do you need to do if you become unwell and symptomatic, and what do we need to do? Rehearsal and monitoring. That's self-explanatory. And clarification of the relapse prevention signature. The relapse prevention signature might not be apparent the first time you work with somebody. It might become apparent if they relapse, but it could be that them or their carer are quite insightful about what was going on and what actually is their relapse signature. Okay, so the identification of relapse signature and the drills that go with it form an ideal medium through which you can establish a common ground with the patient and acknowledge his or her point of view. We can't do relapse prevention to people. They have to come along for the ride, as do their carers or family. They might grudgingly come along for the ride. It might be just they're jumping through a hoop to get you out of their lives, and it's usually signing off on this is usually the last piece of work you'll do with somebody. But if their family or their carers are involved, it always it's good to have people involved so that even if the person doesn't know they're becoming well, the family can flag it with us. So the initial sessions, focus on individuals' understanding of their illness and the perception of risk and controllability of relapse. There are often people you will meet who have absolutely no understanding of their illness whatsoever, or what has led them to become this way. And I think it's really important that we use normalization techniques and that we look at their stress and vulnerability and help them to make sense of it all. And there are a huge portion of the population who go, I have no control over this. And actually, they actually have far more control over it than they think they do, but they just haven't been ever put in a position that control is acknowledged and that is handed over to them. So other people then have negative beliefs about their ability to cope or to act when the early warning signs are identified. And I would always say to the people that I'm discharging, and we've done the relapse prevention drill, and I would just say to them, lads, I don't want you to arrive and say, well, 3 weeks ago I noticed X, Y, and Z. If you notice X, Y, and Z, if your sleep gets knocked off, I need to know about it within a couple of days. Don't wait until the sleep goes wallop and then the next domino falls and the one after that and the one after that and the one after that. We need to try and catch this, nip it in the bud as early as we can so that the wheels don't completely fall off the wagon. Yeah. So it's about, saying to people, it doesn't matter if it turns out to be nothing. If it turns out to be nothing and you've contacted us and it's nothing, well, then that's fine. But if it turns out to be something, at least we're in there early. Okay. And people's fear of relapse can be very easily coped with. Yeah, so we can just teach them the skills and that that's a safety net, that these skills are their safety net, that these skills that they can put into place if their sleep goes wallop, if their stress levels rise, if they start to overthink, if they can't relax. So if you can't relax, then you need to be doing your relapse prevention. If you're overthinking, then you need to be acting on that and you know, using the skills you were taught, you know, around overthinking, things like that. Okay. If people are already doing positive things, well, then that needs to be, you know, identified and, you know, acknowledged and go, well, that's absolutely brilliant. And here are another set of skills that we can use as well. Okay. And all of this happens, and, you know, in the context of general psychoeducation. If somebody's not taking their medication, well, then, and that leads to a relapse. The general psychoeducation about the importance of medication will pick up on some of this. Yeah. So that's so the general psychoeducation comes in to play. But like I said, relapse prevention starts with your very first, even in your own head, the relapse prevention starts with your very first interaction with the patient. I think it's really, really important that you acknowledge that there's so much information that you can be gathering along the way that will lead you to this place of doing a relapse prevention plan with somebody. So the aim of identifying a relapse prevention signature. So you look at a hypothesis about the individual's relapse signature. So it's a set of idiosyncratic symptoms occurring over a particular period of time that serves as an early warning signs of relapse. Okay. So you're looking at an introduction and examples of early warning signs with people. Okay. So you review, you know, you introduce what the early warning signs may be, you go through the early warning signs questionnaire with people, and you review it either with the patient or with the family. Okay. And you're looking for, you know, in the interim time coming up to you becoming unwell, you know, what were the thoughts and feelings and perceptions and behaviors that was going on, and as well as looking at what triggered these events. Were there psychosocial stressors? Was there, you know, was there an increase in drug taking? Had they stopped taking their medication? These are all the things that you need to be looking at in this phase. And two of the exercises that you can do to expand these set of early warning signs are timelines and a card sort. So a timeline I spoke about quite extensively actually at the last session. Okay, so to just go through it, you know, a little bit faster this time. So the individual is supported in constructing a timeline of significant external events proceeding backwards in time for the date. So the difference with this timeline, I suppose, is that we're starting from today and we're going backwards. So what happened today, what happened last week, what happened last month, you know, and what was going on for you in terms of your mental state at that time. Okay, things that you can use to help trigger the memory of people might include, you know, special events or activities, or that was the day it snowed, or that was the day of Storm Barra, or, you know, that was the day of the election or something like that. Okay. And then the early warning signs that are identified as part of the timeline are pegged to the external events. So the night of Storm Barra, I didn't sleep very well. And then for the next couple of nights, my sleep was knocked off. And then I started to become a little bit more suspicious of people. So the early warning signs can be pegged to external events at times. Okay. And like I said before, the external events can be used as retrieval clues. And also you can use these external events to further expand on changes in thoughts and feelings that a person experienced on the run up to their recent episode. Now, if you're doing a timeline with somebody, just as a normal part of your psychosocial interventions with somebody, as part of your normalization process, as part of your helping people to make sense, well then when it comes to doing the relapse prevention strategy, that piece of work's already done. So you don't need to be doing the timeline just in relation to this. And then the other one is what Birchwood talks about quite extensively is the card sort exercise. Now, it's as simple as buying even 2 packs of playing cards and putting stickers on them and writing out the things that are coming towards you in the next couple of slides. And it's that a person goes through set of symptoms, and they can identify which ones apply to them. All right, so just wandered off on a tangent talking about that. Okay, so they describe non-specific psychotic symptoms, okay, constituting early warning signs of psychotic relapse. But actually, you can also add in the ones so that you can see that they're not just specific to psychosis, that it can be specific to depression or bipolar disorder or things like that. But just for the purposes of this, I'm using the ones that are described in the article. Okay. So cards are selected that represent symptoms experienced by the patient in the run-up to this relapse, okay? And the cards are arranged in order of onset to form the basis of a personal relapse signature, okay? So then patients are encouraged to personalize their signature to the use of idiosyncratic early warning signs not mentioned, okay, through personal descriptors or the symptoms identified in the card sort. So people can add. It's not just about the cards. People can add to the cards so that the things that are specific to themselves also get a mention. Okay. So and a lot of this time, the discussion, this all generates great chat, and in the course of the chat, it generates a huge amount of really, really rich data in terms of a person and their life and their experiences of their illness. And it also provides clarity as to what their stresses are, and also at what point did their insight fall away. Because I'm looking after a lady now, and she was very, very psychotic, but she has never lost her insight. She's very, very well aware that she was psychotic. She knew she was sick. She knew she was psychotic. And then there are other people who become psychotic, and within it almost feels like within 10 minutes of them becoming psychotic, their insight's gone out the window. Okay, so even if you can identify the length of time it takes to lose your insight, then it also, that can be included in the relapse prevention plan as well. And also it can be used as going like, it was at this point and it was very quickly that you lost insight. So it's really, really, really important that if the early warning signs emerge or you identify them, that you get to the service, because if we can get you before the insight is lost, that would be absolutely wonderful. And it just helps the patient and their families to make sense of their experiences. So the card sort goes, there are, the cards are divided into different groups. So then there are cards that deal with your thinking and perception. So, a person takes the cards and they turn it over, and you just chat to them about it. Were your thoughts racing? Did you notice that your thoughts were racing? Yeah. Did you notice that you started to think you had special powers? And if they say yes, well then, what did that mean? What were your special powers? Things like that. So all of these questions generate conversation. So the first thing, it doesn't matter what order you go through the cards in, whether it's to do with thinking or perception, you can have them all shuffled up. It doesn't really matter. All right. But these are the kind of questions, or these are the kind of things that would appear on the cards. So obviously thinking and perception, ideas of reference, thought broadcast, things like that. And these are just more of the thinking and perception ones. Feelings. At what point did you feel sad or low? Did you feel anxious or restless? What did you notice started to happen first? Can you order them? Can you say that you were feeling helpless or useless before you started to feel sad or low? Or did you feel sad and low and that led on to feeling helpless or useless? And it just allows you to try and track through a person's signature and track through a person's early warning signs and have them in order of when they appeared. So I'm not going to read them all to you because that would just be insulting all of your ability to read. But these are the sort of questions that you can ask a person. Behaviors. What I find is that the behaviors are often the first thing that gets noticed. So a person, if we were to go back, might be feeling a little bit confused and puzzled, but nobody really notices that because they can internalize that. But their sleep gets knocked off, and somebody in the house, because their sleep gets knocked off because they're feeling puzzled or something, and that then somebody else in the house can pick up on. So the behaviors are usually the first things that get noticed by the carers, but they're not ordinarily, or may not always be, the first thing that happens. Sometimes if a person can't get to sleep, the other things come after that. But this card sort just helps you to make sense of the timings of it all, and sometimes the timings are crucial. So, did you become withdrawn? Did you stop seeing people? Did you stop going out? Were these the things that you noticed that were going on for you? Or did somebody else notice that all of a sudden you became aggressive and you were pacing and you were, not able to sit down? Or that you weren't leaving the house, or all of a sudden there was more cans appearing of an evening time, or that you were smoking more. So these are all the things that you can sit down and chat to with a person. And none of this will happen in isolation. It will never just happen over one session. These type of things often can take several sessions to work through with somebody. Also, really, what's really, really, really important to know, and a huge piece of work that needs to be done with people, is looking at their stressors. What are the things that stress you out? Is it because you're drinking more and taking drugs? Did they have a loss? Was there a loss of a job? Was there a loss of a person in their life? Was there a loss of their identity? Was there marital disharmony or family discord? Was there, World War III going on amongst their own family? Have they money worries? Have the voices become more critical, and that's leading to added stress? Or have they paranoid delusions? But knowing what people's stress triggers are, and a person knowing what their stress triggers are really, really important. And again, then this goes back to engagement, psychoeducation, and normalizing, and talking about stress and vulnerability with patients, I think, is really, really important. So, the development of a relapse drill. So, or a staying well plan, or whatever it is you want to call it. The idea of all of this is that we are encouraging people to seek help and interventions early should their symptoms start to arise. Okay. So once the early warning signs are identified, then the patient is supported and you make the action plan. The action plan has to be put into place. And the relapse drill has to be discussed and has to be noted. And the early warning signs are divided into levels. Okay. So those that occur the earliest in the relapse signature to those that occur immediately prior to the illness. So if sleep kind of happens in the couple of weeks prior to it, and then we'll say the paranoia, gets to a really high level, well then if somebody identifies, I'm really feeling paranoid at the minute, well then that's really, really action is required immediately. Okay, so that's a late indicator that things are bad. The early indicators are the good ones to know, and if we could get somebody to come to the services when their early indicators arise, that's even better again. So, in general, early warning signs are non-specific with a low power to predict relapse. Okay, I don't know about that actually. There are certainly in my practice, I've noticed that there are certain early warning signs that seem to be generalizable, like irritability and lack of sleep and things like that, tend to happen in a lot of tend to be noticed in a lot of relapses. So, and interventions are often not used until the relapse signature has progressed and relapse seems likely. Okay, so sometimes that's the case. I however would be encouraging people to be seeking attention in the earliest stages, and like I said, I would much prefer to see somebody and for it to be nothing, and to have a couple of sessions with somebody and steady the ship, as opposed to somebody coming to me when the ship is sinking. it's always easier, I think, to intervene earlier. So I would be encouraging people not to wait until things are critical, but to try and seek help in the earliest stage. But this is what the literature is saying that should happen. And there are people that we know, you know, and people who work in the community. There are people we know, and we know that when they start to decline, it's only going to end one way if we don't intervene, straight away. And sometimes we have to stand idly by and let it happen. But if we can intervene early, well, then that's super. But I suppose what's important to know is that with every relapse, it also gives us an opportunity to fine tune somebody's relapse prevention signature. So the drill is developed collaboratively. You can't do it on your own, obviously. You need the patient that you're looking after on board. And, you know, if you can have a family member on board, it's really, really good. So you play to your patient's strengths as well, you know, and a patient needs to know that this is the stuff that they're good at, and that they are capable of being in control of their illness and seeking help when they need it. Like I said before, if we need the carers on board, we need the carers on board, and if we can have them on board, that's absolutely brilliant, as they often will notice things before the patient themselves notice things. The services and resources. What services and resources are we going to offer this person if they start to become unwell? Past coping strategies and therapeutic interventions are reviewed. So you're going to look at what worked well, what didn't with somebody. Because past coping strategies may not always have worked. Past therapeutic interventions may not also have worked. You know, just because we have said to someone, this is how we're going to do it, doesn't necessarily mean that it was the best thing to do. So, you know, when we're developing a relapse prevention drill, we need to look back. And helpful, effective coping strategies are incorporated into the drill. And I know everybody is sick listening to me saying, we need to know what people do to cope. We need to know what their coping strategies are and how effective they are. And if they are ineffective, we need to know that, and we need to work on putting much more effective, robust coping strategies in place. Okay, so what do we need to incorporate into a relapse prevention drill? So specific early warning signs might suggest new approaches. Okay, so that's what I was saying before about, you know, what do we know about their early warning signs, and what sort of approaches do we need to mitigate against this, whether it's a CBT focused approach, whether it's a psychosocial approach, whether it's a medical model medication approach. What do we need to do to offer further protection? Is it that when somebody's sleep goes wallop, that for a week or two they get a sleeping tablet until their sleep settles down? You know, is it that people get booster sessions of CBT? What are we going to do when we're developing the drill? Okay, what if somebody has anxiety or dysphoria or other affective changes? Yeah, what are we going to do to help them manage their stress levels? Low-level psychotic phenomenon, are they going to have booster sessions of CBT? These are the things we need to be looking at. So each stage of the drill considers 3 areas for intervention. Okay, so the pathways to support. Okay, how do they flag that they need help? Who are they going to call? If you know, how are they going to walk that path to getting some support? As a service, what are we going to do for this person? You know, if we say we're going to do something and somebody approaches the service, we need to do it. Yeah. For example, recently, I had a lady contact me. I hadn't seen her for 2 years. I'd had her in the past on my caseload, and she was extremely psychotic and extremely unwell, and it ended up being an involuntary admission, and it was very traumatic for her. And she called me to say she wasn't feeling well, and I was just going to pick her back up. But it turned out when I went to the chart room to pull her chart wasn't there. So I rang the consultant. She'd been discharged back to her GP. And the consultant was going, well, you know, she needs to get a letter from her GP if she wants to come back into her service. And I was like, no. I said, I asked this lady when her early warning signs appeared that she contacted me immediately, and now you're saying that she's to go back to her GP, she's to wait for a new patient appointment. I was like, that's not what I agreed with this lady. And by the time that whole process falls into place, she's going to be sick and really, really sick again. And to be fair to the consultant, she went, okay, fine, just see her. So if we say we're going to do something for somebody, I think it's really, really important for us to be credible and that we follow through with what we say we're going to do with somebody. And we also need to look again at personal coping strategies. And I'm not going to go into that again because I've said it so many times today. Okay. So the pathways to support. So people are provided with the information of how to contact the services 24 hours a day, 7 days a week. This is Monday to Friday, 9 to 5. This is what we work. The weekends, this is what we work. Outside of those hours, this is who you contact. This is your local A&E, etc., etc. So this is all recorded in somebody's staying well plan. So people need to know what to expect of our service. So if you become unwell, contact the key worker who may do A, B, or C. So are we going to do anxiety management or stress management if A happens? Are we going to negotiate a temporary increase in medication if your sleep goes wild, for example? Are we going to take you out of a very high and stressful environment for a respite admission if things become unwell? Are you going to be offered booster sessions of CBT? Will you come back onto home care until we steady up? All of this needs to be as much as possible. We don't know, we can't predict the future. We don't know exactly what's going to happen for somebody. But if we can have a rough idea about what the service is going to offer to somebody, it just makes the relapse plan far more credible. So personal coping strategies, these need to be included in the plan. Yeah. What works well for you, what you've used in the past that have worked well, and also looking at new ones. So as part of your interactions with me, we went through your coping, and you could now use relaxation, you can now use mindfulness, you can now use thought blocking, thought stopping. These are your new skills. Let's put them into your relapse prevention signature. And rehearsal and monitoring. So we need to be talking to somebody about, if it happens. So say, for example, this happens, well then, this is, the rehearsal bit. The patient and their carers are given a copy of the relapse prevention strategy or staying well plan, and it is put somewhere in an obvious place. I just say to people, stick it on the inside of your wardrobe door. I tend to staple it to the inside of a chart, so that they're obvious for people who know that they're there. Okay. And then, the monitoring is a shared responsibility, okay, between, ourselves and the individuals and their carers. Scenarios are ran through. It's really easy to sit when somebody's well and run through scenarios with them or their family. Okay. And hypothetical scenarios are used. So this is, I suppose, especially when somebody is prone to losing their insight, the relapse prevention, the staying well plan can almost become an advance directive. And you can sit and you can say to somebody, look, we know that when you become unwell, you don't realize that you're unwell, but you're well now. And we're sitting and we're talking about this, and you're agreeing that this is what we're going to do should you become unwell again. And that we can remind you when you're unwell that you agreed to this when you're well. Or, in the past, when you have shown early warning signs, you've put your head in the sand and you've panicked because you don't want to end up in hospital and you don't seek help. But look, this isn't really a good idea. And if we can catch you early, chances are we can give you some CBT boosters, or we can do X, Y, and Z so that things don't get to the point where things are, out of control and you just have a complete relapse of your illness. Okay. So the clarification. So these are the important areas of monitoring, excuse me. Okay, so this is the bit where we talk about replacing existing coping strategies if they're not very good. with more appropriate ones. So we might be swapping out if somebody has a relapse prevention plan in place, a relapse prevention plan in place, and they've had a relapse and we're going back in and we're getting ready to discharge again, we can swap out the coping strategies. What worked well the last time, what didn't work well the last time. Let's swap them out for coping strategies that are more effective. So, and if impending or actual relapse happens, well, then it's, we can frame it in a positive way. Well, look, this is what we learned this time that we didn't know the last time. And hopefully by knowing this, it'll mean that, things will not get to such a stage this time as it did the last time. We'll be better able to manage things. So I suppose it'd be at this point, if I was in a room with everybody, that we would discuss a case study and we would look at somebody's, signs and symptoms and their relapse plan and all of that. It's kind of difficult to do that over the internet. So I suppose in terms of somebody's relapse prevention plan, no two services, relapse prevention, staying well plan is going to look the same. But this on the screen, the next couple of pages on the screen, will just give you an idea of, how to go about, even if you don't have one, formulating one and the sort of things that need to be in it. Okay, so the person's name is PF and their relapse signature is they start to feel inadequate. And because of that, then they constantly preoccupied at self-improvement and looking at their own faults, and they feel increasingly restless and anxious, and their thoughts are racing. That moves on then to feelings of elation and feelings of being quite spiritual and religious, not needing sleep, and then becoming suspicious of people around you, not wanting to eat, horrific thoughts and paranoia. So as you can see, the relapse signature is starting with the sort of softer symptoms, and at the end then, when you're at severe paranoia and tactile hallucinations, things are bad. Yeah. So increased feelings of inadequacy or preoccupied about the self-improvement bits and the anxiety and restlessness, I'd be saying to people, if you notice that, for more than a day or two, you need to be picking up the phone and giving me a ring. And if it's nothing, it's nothing. You know what I mean? It's far easier to manage nothing than it is to manage things when things are really out of control. Yeah. Looking at the relapse prevention, oh my God, no words now, prevention drill, stay calm, do your yoga or meditation, contact your key worker, talk about it. Then step 2, if this person has an emergency supply of medication, to take PRN if they need it, contact with the services if necessary, contact the doctor about, getting a review or taking increased medication. And step 3 may or may not be an admission to hospital. So the other part of the relapse prevention plan will be looking at how that person copes with their automatic thoughts. So, what is the thought? Just to remind them of their techniques, yeah? Write it down. Evidence for, evidence against, are there any other explanations? That piece of work that you will do with people probably as part of their package of care in any case, but have it written down as part of the relapse prevention plan, because what happens is people are well and they tend not to do these things. So they might need just a little prompt to carry on with them. Distraction techniques, what are they? Going to be different for everybody. And whatever it is, whatever distraction techniques works for the individual, obviously it'll be written down there. And coping with problems and stressors. So, if you're able to identify what your stresses are, how are we going to cope with them? And that'll all be written in that part of the plan. So that may or may not be what a relapse prevention plan looks like in your area. But just given everything we've spoken about today, they're the kind of things that your staying well or your relapse prevention plan should contain. And also, the name and number of your key worker and, times places are open and things like that are also important to have as part of the plan. So that's kind of finishes today's session. I really hope it's kind of given you all food for thought. And I suppose if you take away one thing, it's, you know, remember that the end aim is to have people coming to us in the early stages of, you know, their mental health starting to decline, as opposed to arriving when it's a complete crisis. You know, and if we can catch people early, I think that just in terms of, you know, their social functioning, their self-esteem, and their control over their illness, I think, if, you know, the people feel quite empowered if they catch themselves before they fall. And I just think it's, you know, it's kind of important that we have strategies like these, and we use strategies like these with people in order to keep them well. Excuse me, it's my dog coughing. He's beside me to keep him quiet. So yeah, so that's the end of the slides and the session. So if anybody else has anything they want to add or any questions, I'm happy to take questions.
Sinead, it looks like Colette is typing something in there.
Okay.
Sinead says, Colette just said, super presentation, Sinead. You've walked through the process of empowerment very well. Thank you.
No, thanks, Colette. Okay. All right, if nobody else has any more questions, I know we're finished early, Anya, but yeah. Do you want to have you closing remarks to make?
Perfect. Thank you so much, Sinead. That was brilliant. Even I'm not from a nursing background at all, and I find that very interesting. And thank you so much again. I'm just going to put in I'm just trying to paste it in, our Christmas event that we're having tomorrow evening. I know Aisling has sent it out to a few people. It's a lovely evening that we have as a program of some music and poetry. So be delighted if you could all make it. I'll email it out to you all if it doesn't go into the chat now. And also just a reminder to sign in. I'm just going to reshare that again. And it just means that you will receive certs and slides from Sinead's presentation. Yeah, so thank you very much.
Thanks a million, Anya.
I'm not as good at this as Catherine and Aisling.
That's perfect. Listen, thanks a million, Anya. We'll chat to you soon. Take care.
Thank you, everyone. Have a lovely Christmas.
Bye.
Bye now. Bye-bye.
Bye.
Thank you.